Hello and welcome, everyone. Thank you for joining us today. We're so pleased you could be here as part of our online communities for today's In Conversation With. A huge thank you to KPMG, our presenting sponsor. Thank you so much for your enduring commitment and support to the health of women and health equity for all. We're so grateful to KPMG for your leadership and your support of Women's College Hospital. I'm going to start today off with our land acknowledgement. Before we begin, I'd like to take a moment to acknowledge the land upon which we gather here today and acknowledge Toronto as a sacred gathering place for many Indigenous people of Turtle Island. With much respect, we uplift the sacred diversity of Aboriginal peoples and caretakers of this land that we work, live, and thrive on. I'm joining you today from the ancestral homelands of the Adirondacks, the Huron-Wendat, the Anishinaabe, the Mississaugas of the Credit First Nations, and the Haudenosaunee territories and nations, home to Dish with One Spoon. This treaty is based in stewardship, reciprocal sharing, sophisticated governance, and healing practices, which extends to all nations living here today. We acknowledge the Indigenous people across many territories you all live and work in as well, and all their unique expressions, richness, knowledge, lived experience, and history. Okay, before we get started, there are a couple of housekeeping items. We're all on Zoom and we've been on it for 2 years, so we're probably all well acquainted with it. We are recording today. We're gonna have you muted so you don't have to worry that we can hear what's going on at home. There's a Q&A box down below, so please feel free to ask questions throughout the conversation. We're going to hold them to the end, and then we're going to have a little bit of a Q&A at the end. So please have your questions coming in. We have someone curating them, and we'll ask them. And there'll probably be lots that are the same, so we'll ask them about the big themes. Okay, I hope you guys are all ready. I'm so excited about this conversation, and I'll be honest, my mom is watching, so I'm a little bit more nervous than normal. But I'm going to start off with introducing our guest for today's In Conversation With. And I have to tell you, I'm going to read her extensive introduction because we really need to know we should know how important it is to have people like Dr. Rochon leading this work and the expertise that she brings to it. So here we go. Dr. Paula Rochon is the founding director of the Women's Age Lab here at Women's College Hospital. And for those of you who are new to our family and our community, you know that Women's College Hospital was Canada's first women's hospital, founded by Dr. Emily Stowe. And it was the first place women could practice medicine and actually treat people. So Dr. Rochon is in a long line of trailblazers. She is a geriatrician and a senior scientist at Women's College Hospital. She's a professor at the Department of Medicine at the University of Toronto, and is the inaugural RTO ERO Chair in Geriatric Medicine. Dr. Rochon's research focuses on understanding the unique needs of older adults, particularly older women, and promotes their health and wellness. She has made considerable contributions to our understanding of aging and its impact, both on individual patients, but also at a system level. Among her many outstanding accolades, most recently, Dr. Rochon was appointed as the chair of the Canadian Institute of Health Research Advisory Board for the Institute of Aging. She was invited to participate on the advisory group to support the Ontario Ministry of Long-Term Care in developing a long-term care staffing study. She was invited as a member of the National Task Force on Long-Term Care on the Long-Term Care Expert Panel on COVID-19 for the Government of Canada. She is also a member of the Ontario COVID-19 Science Advisory Table, where she chairs the Congregate Care Setting Working Group of the Ontario COVID-19 Science Advisory Table. Dr. Rochon and her team at Women's College Hospital and the Women's Age Lab have published hundreds of peer-reviewed articles on their work in aging, and have also recently garnered attention, including an op-ed in the Toronto Star calling for a national aging strategy that includes older women. So 2 facts from the article that really stood out for me was first that Canada has only about 304 geriatricians, and that means there's only one geriatrician per 100,000. So for older adults, there's one geriatrician for about 20,000. When we compare that to pediatricians, there are 2,300 pediatricians in Canada. So an enormous gap, despite the fact that there are far more older people than younger people. Second stat that really stood out to me was that 93% of older adults live in the community rather than in assisted living. I think there's a long held belief that many seniors, or a large majority, live in assisted living, and that's just not true. I was shocked by these numbers. And then I was further shocked to find out we actually don't have a national strategy or a plan for this huge aging population, what has been considered the greatest population that we've ever had, one of the largest. So it begs the question, why so little attention is being paid to older adults, and particularly older women? You know, it is a privilege to grow old, and we all hope to grow old, but we're not paying attention. Why not? The response to today's event, which this is by far the largest group we've ever had for our In Conversations with, really means that I think that this is resonating with people on a personal level. It's deeply personal, and we all want to create change. I want to talk about the fact that Dr. Rochon and her team are doing crucial work. And I know that you're as excited as I am to learn more about the Women's Age Lab and how it's helping to shine a bright light on the needs of older women and close some of these glaring gaps that we're seeing in the population. Dr. Rochon, I'm so honored to have you here with us today. So let's dig in. All right, here we go. I'm going to start with our very first question. Dr. Rochon, question one. I shared some of those amazing stats at the beginning from the op-ed that really point to the glaring gaps in support and care for older women, but the picture is much bigger and much more urgent and complex than that. Can you share a little bit about the current landscape for older women in Canada and what's happening right now and why this launch of this Age Lab is so necessary at this time and why this unique research is so necessary?
So Jennifer, thanks so much for the introduction and the opportunity to talk about Women's Age Lab. You know, but in reference to your question, I think we might be able to rephrase it actually to ask, why has it taken so long for a center like this to come into being? And why hasn't it already happened? I mean, as you say, let's just look around at our friends, at our colleagues and families, and we all know older women, and we all see the opportunities and we see the challenges that go on with aging. So as a geriatrician and a researcher, as you've mentioned in your comments, I've spent literally decades caring for and studying women, both in the community and in the long-term care setting. And from the very start of my career, I was struck or you know, I just found it was unbelievable by the many instances I saw where women were not receiving care tailored to their needs, probably because the research evidence didn't exist to guide this care. We're about to become what's called a super age society. You know, I use this term, but I think it's really important. You know, this means that 20% or more of people in Canada will be 65 years of age or older. And there are now more older people than there are children in our country. And you mentioned that in your remarks. Right. But the majority of older people are women. And we really do, as you say, we need a strategy now for the country that has a focus on women. So, you know, when you go back to your question again, why now? Why is this the time for Women's Age Lab? In setting up the Women's Age Lab, we couldn't find any other research center like it in the world that focuses only on women. Right. And I think that's shocking, maybe a little bit chilling to think that, to our knowledge, we're going to be the first such center focusing on women in aging. So I think really the timing is now. And honestly, I can't think of a better place to establish a center like this than at Women's College Hospital, where we've had such a rich history of being leaders in women's health.
Well, we're known for making history, obviously, in women's health. We're trailblazers, but we're going to delve into this a little bit further and really talk about women. And, we're going to have the question come up again and again. And I'm sure people are already thinking it. I see the little bubble over people's heads, like, why just women? Why not just older people? And what I'm going to say is that, I worked in children's health for a long time. For 9 years, I worked at McMaster Children's Hospital. And I tell this story all the time because I've been at Women's for 3 years. Never in my time there did anybody ask me why we needed a children's hospital or why we needed children's research. People intuitively understood children were not adults and they would benefit from having specialized care facilities, people trained to take care of them. But when I got to women, people ask me that all the time. Why not just everybody's healthcare? Why do you need a women's hospital? So I'm going to ask this question. We're lacking in ways to support the older adult population generally, not just women. But how are women unique, and why should we focus on them specifically, Paula?
So I think older women are unique in a lot of different ways, and probably a lot of ways that we don't even know yet. For example, there's medical conditions that women experience more than men. So like we think about things like thyroid disease, we think about arthritis, we think about headaches, migraine headaches. And women are also more likely to experience drug-related side effects. So these are things that are different, but they also can present differently than men for the very same medical condition. So for example, one of the things we like to talk about here is heart disease, the leading cause of death in women. But when you look at textbooks, they generally describe what we might think of as more classic kind of symptoms, things that might be more common in men. So things like, for example, chest pressure radiating to the neck. Well, women may present with these symptoms as well. They may well do that, but they can also present differently with things like maybe describing a burning kind of pain, or other things like they just feel fatigued or lightheaded or things like that aren't really quite the same. And without focusing on these differences between women and men, conditions that are very important for women will be missed. And there are likely many, many other medical conditions where women and men differ that we're just not aware of because those differences haven't been studied. One of the things I've talked about a number of times is that, it wasn't until the early 1990s that women needed to be included in the clinical research funded by the major US funders. And not until just a couple of years ago, 2019, that these studies were required to include older people. So I think this in part explains why there's that lack of information about diagnosis and treatment of health conditions for older people, especially for women. So, as you've said, we need to ensure that we're getting sex and age disaggregated data so that we can learn about women in everything that we study. And we've really not paid enough attention to really this fundamental issue, I would say. And that's one of the things Women's Age Lab will help to do.
Well, I think you've touched on two really important points. One is that women as a group were not included in research studies until the late 1990s. I didn't know that until I started working at Women's College Hospital. And I certainly didn't know it wasn't until 2019 that older women. So you can see when you have a gap like that in research, why things don't land and you just don't have the background and knowledge to really treat women the way they need to be. All right, we're going to go on to our next question. So you're a trailblazer like so many of the women that work at Women's College Hospital and the researchers that work here. With no other center like it in the world, you mentioned that, how did you go about establishing the Women's Age Lab and where did the concept come from?
Well, I think it started out with the idea that we really needed to focus on this area. So there was a need for a focus. So I think that was a given. And for me personally, it was really the culmination of decades of research that have focused on that kind of intersection between women and aging. And while we knew that we wanted to focus on this area, we also, I think we're starting to appreciate that just doing the research wasn't going to be enough. We also knew that we needed to take that science and we needed to find ways to actually put it into practice. And we wanted to make sure that we're also talking about and advocating for change. So the concept itself evolved from talking to many people, leaders in research, clinical care, education policy,
Right.
media people, community partners. We also worked with the Retired Teachers of Ontario. They're an amazing group of 80,000 retired educators, mostly women, and they provided us with a lot of information through focus group and surveys that were also helpful to our thinking. And through this process, I just want to say, sort of thank you. And we've been amazed by the response that we've received to Women's Age Lab. Everyone has just been, so generous, willing to help, positive. People offering up their stories about themselves, their moms, their friends. Everyone who we talk to also say, yeah, this is really needed. So
Yeah.
I think by listening a lot to these people, we learned a lot that helped us move forward. So that's got us to where we are.
Well, that's great. I know that when we first started talking about this about a year ago, Paula, and just by the attendance at the webinar here today, that people are incredibly interested in this area. And, right from the beginning, we knew that, older women are facing gaps, and we don't have to tolerate these gaps anymore. I always say to my friends, we have the numbers, we're 51% of the population, and we all hopefully have the privilege of growing older. But during the development of the Women's Age Lab, it became clear that language around aging is critical to the way we see and think about aging. And so even the name of the Women's Age Lab is very specific, and we've used language in a very specific way. How did you come up with the name, and why did you choose to name it the Women's Age Lab? Because there are some, more obvious names, I would say, like Older Women's Research Institute, Older Women's something or another. Why the Women's Age Lab?
Well, I think for me, this was one of the most interesting parts of the process.
Right.
As I said, we did lots of consultations. We talked to a lot of people, but something that came out that perhaps we hadn't maybe expected fully was that the word old is, contentious.
Yeah.
Some people, I think, to be honest, feels that it devalues them.
Yeah.
And I think most people don't view themselves as old. So we found, first off, defining old difficult.
Right.
But it's interesting that, for example, the World Health Organization uses the age of 60 to define old. And I think that might be a little young.
I think so.
And if you use that definition, though, there are now 1 billion people who are 60 years of age or older in the world.
Right.
Right. I think there's also the age of 65, which is probably the age we think about more here because it's retirement age.
Right.
But let's think about that, with increasing health and longevity, people are living longer in retirement than they did in their workforce years. And so this may no longer be appropriate. And then the bottom line was basically, it was simply relative. Those who, it was, who's old, it's somebody who's older than you. That seemed to be kind of the message we got.
Right.
We also realized that, this isn't just us that's sort of, struggling with this word. The Journal of the American Geriatric Society, which is sort of one of the big leading geriatric journals in the world, really, put out a whole section on the language to use and not to use when talking about aging. And, words like elderly, for example, don't use words like that. So, they've had huge discussions about it. So we like the term aging because aging is part of a lifelong process. We're all aging. It's all part of everything we do. Right. So we felt that, using the term aging and using the name Women's Age Lab is a great way to convey that concept. And also it's kind of dynamic and it's positive. And that's what we want to get at.
Yeah. It's so strange that we all want to grow old, but we make aging such a negative thing. And I love the fact that and the word lab, to me conveys the idea that it's something that's, being explored and, it's part of, research, and you're trying to expand it as opposed to, something that is finite. I love the idea that it's a living laboratory, that we're just learning and building on things.
Yeah,
so
being open and inclusive.
Exactly. All right. So let's talk a little bit about why we're here. And, let's talk about, that aging is not just a Canadian problem. It seems like the whole world is ignoring this, and it's a global problem. Can you talk about the global impact that you're hoping that your work will have. And I mention this because, you know, a lot of what we do here at Women's College Hospital is not just about our organization. And in fact, we were sort of reborn to really be a system changer. And I think the Women's Age Lab really plays to that strength and that unique mission really well. So talk about our global impact and why we will be making a difference globally.
Yeah, I think it's very clear that the work we're doing here starts locally, but it is something that's global in its impact. So as I said, right now we have 1 billion older people, so clearly relevant to the world. We have 7 million people over the age of 65 in Canada and approaching 3 million over the age of 65 in Ontario. So, and the reality
wow,
is
that's almost half. That is almost half of the elderly people in Canada live in Ontario. I'm sure many of the people that have tuned in today did not know that.
Yeah, 2.7 million in Ontario. And the reality is most of these are women. So I think, you know, from a demographic perspective, it's important.
Right.
But well, there is some really important momentum building around aging around the world that we want to pay attention to. It still lacks, in my view, a focus on women. But some very important initiatives. So just in 2021, the United Nations launched something called the Decade of Healthy Aging, which is a huge global effort to improve the lives of older people. And they've identified priority areas that will be, you'll see, align with the work that we're doing here. The World Health Organization has also just launched a Medication Without Harm campaign. And again, they're targeting polypharmacy, which is something that we talk about, which is very important for older women. And then there's another global campaign to combat ageism, aimed at really changing the way we talk about aging and older adults, you know, just sort of relates to our earlier discussion here. But it is important to mention that even the UN in their Decade of Healthy Aging, they talk about women. So it's part of their strategy, but they haven't identified an action plan specifically for women. So we really have to take it to the next level. And that's the work that, you know, we'll be talking about that we're hoping to fill.
Well, I love this idea, Paula, because Dr. Rochon, because I think we're acting locally with a global, you know, with a global impact. So we're thinking globally, acting locally. And I love that, you know, it's going to flow both ways. So I want to talk a little bit about the research. And, you know, the fact that this is not about other people elsewhere. As you just said, we have, you know, almost half the older people in the country living right here in Ontario. And, you know, we have to lead in this area and everyone has a stake in it. So learning more about how to improve the lives of, you know, ourselves, you know, generations to come, our children. I know you've structured the lab in 4 key pillars because it's like such a big area to tackle. You know, where do you start? And I love these 4 pillars that you've created to get us started. So I'd love to dig into why you've chosen to focus on these 4 key pillars and, you know, how they're going to get us to that model of healthy aging and longevity.
Yeah, so thank you. As you said, when you're talking about this area, you know, even though we've gone from aging to focusing on women, you think we're focusing, but it's still huge. So we focused further. So we came up with these areas, these pillars, because we wanted to make sure that they aligned with our science. You know, there were things that we were already really doing. We also wanted to make sure they aligned with, you know, international initiatives, and I just mentioned some of these, and also focus on our priority areas that women said were important to them to improve their lives. So we worked really closely, I just want to point out, with stakeholders to help us establish and define, and I would say refine these pillars going forward. So first we have one on reimagining aging in place and congregate care. And I'll just say congregate care is a way of referring to settings like long-term care. I know it's a bit of a fancy word. And reimagining aging in place. So that's, I think, something that's important to all of us. Optimizing therapies to reduce harm is another pillar. Our third pillar is promoting social connectedness to reduce loneliness. And then our last pillar is about tackling gendered ageism. And throughout that, and you'll see on the image that you've got here, we have a kind of a cross-cutting tool, which is the use of sex and age disaggregated data in all fields as a real starting point to learn about women and men in these diverse areas. And Jennifer, you did mention, earlier on, aging and women. It's interesting that a lot of men have come up to us and said, where do we literally fit into this picture?
Right.
And it's been interesting because we say, remember when we talk about women, we learn about men.
That's
and
right.
by exploring health and social conditions with a focus on older women and by collecting data stratified by sex and age, we are also really learning about men.
Well, what really struck me when I looked at the pillars the first time and when we started talking about where to begin, I think a lot of people thought we would stand up a clinic or a program here at Women's College Hospital that we would, funnel people from the Greater Toronto area or across Ontario into. And what I love about the 4 pillars is it's not about a place, it's not about a program, it's really about changing a mindset and approach to how we look at women's health and women's aging. And it really plays to being able to scale it anywhere. What we learn here can be implemented in BC, can be implemented in Europe, can be implemented in Africa. It crosses all borders. It's not localized in terms of its impact. And that's what I love about the things that you've identified as the 4 pillars. The other piece is that it really shows that over time, healthcare does not take place in the hospital. All right. A lot of healthcare takes place in the community. So I love how those threads are brought together. All right. So we're going to talk a little bit about one of the pillars that you talked about, which is congregate care. It's been a really hot topic during, COVID. We know that the vast number of people in congregate care are women. Can you tell us why it's so important to talk about this pillar and how it relates to the Women's Age Lab?
Yeah, so I think long-term care has received a lot of attention, and it's something that's always important. But when we talk about this, I think it's important to remember, as you brought up at the front in your remarks, Jennifer, that the vast majority of older women live in their homes, and generally they want to stay there. But women do make up the majority of long-term care home residents. So in fact, about 2/3 of long-term care residents are women. 80% are 75 years of age or older, and they tend to have multiple medical conditions. And that makes it really, really important to find ways to support women so that they can get the care that they need in long-term care. And also, when appropriate, stay in their homes if that's what makes sense for them. And I think it's true that we have seen such devastating impact of COVID-19 on residents in long-term care. Yet, despite that, people do not realize that it's women that have been so largely impacted by this terrible pandemic. So we've been doing a lot of work in this area, but one piece that we're working now is creating guidance on what you can do to help keep long-term care residents safe, particularly now during Omicron, where it's again an important issue.
Well, you've talked a lot about, the different things that we can do. And, one of the things I didn't realize about particularly prescribing and drugs is that women are prescribed much more heavily prescribed drugs than men. And we have the vast majority of adverse reactions. And I think it goes back to what you talked about. We were not part of the research trials, and therefore that's to be expected. I want to talk about what the Women's Age Lab is doing in terms of looking at reducing harm from medication, because I think this is a really big area that we need to talk about.
So medications are certainly very important to women. 1 in 4 people are taking 10 or more medications. And I think, let's be clear, medications are very important and they're often used for chronic conditions. And so that's a good thing. But it's also important to remember that potentially inappropriate medications use is highest in older women. And this is even more important because older women are more likely to develop drug side effects that can lead to harm. So the piece that we get at here is we really need to find ways to tailor drug therapy to meet the specific needs of older women in order to reduce that medication harm. And speaking personally, this has been the central focus of my research for a long time, which goes back to my personal experience as a geriatrician caring for residents in long-term care, where I saw just firsthand, I would see it right there in my day-to-day practice, how many medicines that I prescribed to frail women were being split because they were not manufactured in the lower doses that were appropriate for these women. And when doses were too high, it causes harm that could have been prevented. And as you said, Jennifer, this is, I think, really a direct result of not doing the research in older women so that we had that information. There's drugs that are out there on the market that have been there for a long time where studies didn't consider women, and there's been big impact of those.
Can you share one of those great studies, because you've highlighted this before, and it would be really important for our audience to hear like a real life example of how this plays out in the real world.
So one of the examples, probably the most well-known, I would say, that people talk about is an example of a drug called Zolpidem, which was a commonly used sleep aid with, literally millions of prescriptions, mostly to women. And it wasn't until it had been on the market for, I think, about 20 years that studies were done that recommended cutting the dose in half for women, because it showed that the full dose had lingering effects that seriously impacted people's ability to drive. So, women ended up, now it's recommended they would have half the dose that are used for men. But that's just one example, and you can imagine many drugs out there where there may be similar situations.
And many of the commonly prescribed drugs that we use, like somebody said to me, aspirin was probably never tested on women. There are many drugs that we commonly take in day-to-day life that were never researched on women, much less older women. And I know even at the beginning of COVID, people were talking about, do we have enough older people and women in the research studies? So I think this goes back to your point. There's a bias set up in the system, and we've seen it for a long time with women being included. And that bias is reinforced in terms of as this ageism, where women that are older are excluded. They're literally left out completely. So you have this compounding effect. And so you can see how important it is to be conscious of who is at the table, who is missing. And when you talk about that, when we say women, we also mean who's missing in terms of the intersectionality of race and culture and background, because we know all of those things impact how things land.
That is so true.
All right, so let's talk a little bit about moving this into the global impact and why this conversation really has an ability to move the dial globally. You've done a ton of work in terms of prescribing cascades, and that's changed how people are prescribed medication all around the world. Tell us about what you and your team are doing to set the standards of care that will improve the lives of all people. Like I said off the top, what we're really trying to do is not just move the dial here at Women's College Hospital or in Toronto or Ontario, but globally. And then as well, tell me about the research around loneliness, which has become such a hot topic, especially during the pandemic, but even prior, that's really been top of mind. Talk about how those two things you guys are leading in. And
so you mentioned prescribing cascades, and that's happens when an individual is prescribed a medicine to treat the side effect of another medicine they're already taking.
Right.
And the reason they're important is they contribute to polypharmacy, which means taking multiple medications, 5, 10, whatever the number is, medications.
Right.
And it's, as you say, one that we created a number of years ago, and now it's being included in de-prescribing protocols that are used by clinicians, around the world to help, improve the way medications are prescribed. So we've been studying prescribing cascades using data in Ontario, and we've identified more than 100 different prescribing cascades. And we're now looking to see how they get linked to serious events. But perhaps more interesting is, especially during this sort of global time, we've been working with investigators from 6 different countries, people from Ireland, from Belgium, from Italy, from Israel, United States, and Canada, to explore prescribing cascades that are occurring in their country and exploring how they're different in women and men, in their countries, and exploring how we can prevent them. So the idea is if we can prevent these prescribing cascades, we can reduce polypharmacy and therefore reduce the harm and benefit women at an international level.
It's just wonderful. I don't think people realize that people take drugs to offset the side effects of other drugs. And that just proliferates the number of medications that a person can be taking. And since women start off taking more drugs, we can see how that, grows and grows and grows. And it's amazing that you're leading this work that can change that for women all over the world. So let's talk a little bit more about loneliness and the impact of loneliness, because I think, my mom's 80. I hope she's watching. Sorry, Mom, I said you're 80. She just turned 80. I'm so excited. But, she lives alone. And at the beginning of the pandemic, that was one of the most painful parts for our whole family, was trying to, make sure she was taken care of and that she wasn't lonely. And it's almost impossible to avoid as you get older, especially since women often outlive if they're married to a man, male partners, they end up being in their house alone, like my mom is. So let's talk about loneliness. And it's not just for people that live in their homes. It is even people that live in congregate care. My father was in long-term care before he passed away. And there were lots of people that didn't have a lot of visitors, and it was quite lonely for them. So let's talk about loneliness and what you are focusing on at the Women's Age Lab to address this.
So I think you're right, Jennifer. Loneliness is something that impacts everyone, especially women. And honestly, during COVID, I think we can all say that we've experienced loneliness.
Right.
But women are twice as likely as men to live alone, and 40% of those women living alone describe being lonely. So it's interesting that it's important, not just in itself, but also because it impacts health. And one of the things I find interesting is the former US Surgeon General said that the negative health impact of loneliness is like smoking 15 cigarettes a day.
Oh my goodness.
So we know too, as you've described when you mentioned your mom, that being, people have been more isolated during the pandemic. They can't go to community spaces. They can't do the volunteer work they're used to doing. And as you said, sometimes can't even meet your families.
Right.
So this is such an important area. And at Women's Age Lab, research led by Dr. Savage, who's one of our team members, is looking at the link between loneliness and health among people in Ontario. So using data from everyone in the province, she's able to explore the impact of loneliness on health system use. And she's also forming cross-sector partnerships so that we can work together with community groups to propose solutions. So we're really finding ways to act in these things. She also did some really interesting work that just came out that used data from Ontario long-term care home residents to look at the impact of not having a family member or close people visiting on excess deaths during the pandemic.
Right.
And they found that long-term care residents who had no personal contact, none, with family or friends had a 35% greater excess mortality than long-term care residents who had contact. And I just think that's one example of the importance of having social connections.
Of course.
It really does make a difference. But we're also exploring interventions to look at loneliness in our cities. Older adults often live in apartment buildings and condos, but don't necessarily connect with the people that are around them.
Exactly.
So we're working with cities and colleagues to figure out how do we take advantage of this thing of people living in close proximity to explore how providing health and social care in these buildings could reduce loneliness and improve health.
So can you share some of the examples of how this works, in the real world, like practical ways? Like, can you give us some examples of how it's working if you've seen it elsewhere?
Yeah, so one of the things that we really like to do at Women's Age Lab is to look at what's happening internationally, because we get such great ideas and things that we can potentially bring back here. And likewise, obviously, things we're going to be sending out. But there's, for example, an example of a small town in Germany that they call the most age-friendly city in the world.
Oh, I love that.
And there, they've created affordable housing where younger and older people live, in close proximity. And they have whatever you need is in walking distance. And it provides an opportunity for aging in place. And it's been very thoughtfully put together. The city in Germany that is the most age-friendly city has a department of what they call future aging, which I just love that name.
I love that name.
Because it's
so powerful.
It's focused on shifting mindsets away from what people can no longer do, instead of focusing on what they can offer. And I just think it's an incredible sort of way of doing things that I think we have a lot to learn from. There's also, in Canada, some great programs. One of them is a home share program where students, you can imagine university college students looking for places to stay, don't have a lot of money, hard to find accommodation in some of our cities, are put together with older people who have homes and maybe would like some companionship and, some additional income. And I think this kind of arrangement provides, companionship and connections that benefits both students and older adults.
I agree.
Really
some wisdom and some coolness and some tech savviness all together in one house. I think that's a wonderful combination. In multi-generational homes, where the way we lived for so long, it makes a lot of sense. I want to get to this shifting mindsets. I know there are so many other examples. I know the UK, for example, I think you had told me about, they have a minister of loneliness. And I think that mindset of, being lonely is not okay. It's not the norm, and that we have to not accept it as the status quo as people age. I'd love to talk about this idea of shifting mindsets. And so that we start valuing, like you talked about, instead of making growing old a negative, make what you can do a positive, and the contributions of older people. And I think that's particularly true of women. We have to change our own mindset of our value, and that aging is a privilege, and we have something to offer as we age, and we can still participate in society. So this is a great segue to that fourth pillar of what we're calling a gendered ageism. That's not a term that maybe a lot of people know, but we're hearing it more and more, and it's pretty complex, and it means a lot of things. Can you describe what it means and how it's really impacting the health of older women?
Yes, very important area. So gendered ageism, I think, is something, as you say, people may not be so familiar with, but I think we should start thinking about it. It is very important. And it's basically the idea that women face discrimination both on their age and on their sex. And that's what we call gendered ageism. And it's something that, often kind of goes unrecognized, sort of flies under the radar. But it is really a theme that you might imagine underlines all of our pillars. And it's reflected in so many ways that I don't even think people see it. For example, gray hair viewed generally negatively for older women who will often then dye their hair. It's often perhaps regarded as distinguished from a man. So kind of like a different kind of connotation. So a simple, kind of example of where that may come into play. But there's implications of gendered ageism at a system level. For example, older women face pension inequality. And we know that women are less likely to be in the paid workforce, especially older women today. Way back when, they were much less likely to be in the paid workforce. But women in the workforce are often paid less than men. And they are also taking time away for maternity leave, childcare. And as a result of that sort of thing, they end up with lower pensions. And in fact, this is being looked at an international level. And women are in fact ending up with pensions that are about 26% less than their male counterparts. Yet, we have to remember women live longer than men. So, this means they have less resources when they retire to pay for healthcare type expenses, including many things that aren't covered by insurance, like simple things like having glasses, having dental care, things that really do make
hearing aids, things like that. And, we've heard about the great resignation during COVID, where a lot of, quite honestly, women have left the workforce with all the pressures of COVID and decided to go back home. This is, again, going to impact a whole new generation of women who have stepped away from what we call traditional paid work. So what are we doing about gendered ageism at the Women's Age Lab, Paula?
So one of the things we really think it's important to do is to raise awareness about this issue. I think, Jennifer, as you said, a lot of people aren't really familiar with it and really what it means for older women, and to get people to start thinking about it more critically and to help change the mindset. So one of the things we did is we published an article in The Lancet, which is one of the world's most influential, I would say, medical journals and most widely read on the topic of gendered ageism. And as a result of that article, we were then invited to write another piece for the OECD, which is one of the leading economic forums internationally. And they asked us to write about what this means about, in terms of retirement for women, which is sort of what we were just talking about. So this was an example of an opportunity that where we're taking advantage to advocate for equity and inclusion for women to a non-healthcare audience, and just to raise awareness of these issues.
Right.
And we're looking at the possibility of launching an awareness raising campaign about gendered ageism to really bring this to life for people so they can really see it and understand it. And so we can really start to address it. And, having said that, sometimes it's hard to believe, and I'll just remind everyone that Women's Age Lab officially only launched in October.
I know.
So we have been so busy already. We've had such great feedback and support from so many that we're excited about what's to come. But there's a lot to come.
Yeah, and I want to talk a little bit about that. I mean, it's brand new. We're just in the first few months of the Women's Age Lab, but you can just see by the interest in today's conversation, there's a lot of pent-up demand for this conversation and the solutions. I love that we're focusing on solutions and not just focusing on talking about it. It's wonderful that we're doing awareness, which is the first step. We're doing education by doing these type of webinars, but it's so wonderful to also be talking about solutions. And so, Paula, Dr. Rochon, tell people what's next. What's next for the Women's Age Lab?
Well, I just want to say that Women's Age Lab has been brought to life, I think, through the hard work of an incredibly dedicated and diverse team that we have here at Women's, who bring insights, they bring creativity to the work. And, that's been added to by the collaborators that we've got locally, nationally, internationally, and the input from so many different groups. So we have a team, and we obviously need to continue to grow that team to do the work. But it's become clear to us that no matter how many people we have on our team, it'll never be enough to match the size of where we're trying to get to our vision. And that's why we need to find ways to partner with other research, community-based agencies, other different kinds of groups across Canada and internationally. So we're building these collaborations already with experts in clinical care research, methods, sociology, policy, because the issues facing women, older women, are complex and they really touch, I think it's fair to say, all aspects of society. And of course, of prime importance is that we need to work closely with women from all sorts of backgrounds to ensure that their diverse experiences and insights are reflected in the work that we need to do.
I think that's such an important point. And I hope people have noted as they've listened, Women's College Hospital has a wonderful reputation, not just in research and academics, but in representation and diversity. 70% of our physicians are women, 50% of our researchers are women. That is statistically way off the map of most organizations, where most research centers have about 28% women. So you really have women's voices. You really have the research being led by wonderful physicians and researchers like yourself who have lived experience, and diverse women who bring that lens to it as well. So that cannot be understated. And I hope people realize how lucky we are to have that right here in Ontario, and that we are sharing that with the world. All right, my final question is, so we can't wait to see where we're going to go with this. After just a few months, we can see the acceleration is required and necessary. Before we end off and let people ask a few questions, give some advice on what people should be watching for in their own health, and how they can build a better future for older women and all of us.
Yeah, so maybe I'll just suggest a couple of things, and I'm sure there are many things that we could do, but one of the things we could do is, on an individual level, I think it's important to make yourself aware of the health issues that are impacting women with age, and to make sure you talk to your healthcare providers about what you can do to find ways to improve your health and well-being, as you're aging, as we all are. So I think that's something to do on the individual level. On the community level, I think it's really important to think about what we can do to build age-friendly communities, to ensure that older people, and particularly women, have access to the supports that they need to age well at home when possible. So I think we all need to be engaged in that process. And at a policy level, and I think this is important, all of us need to get involved by asking that we make aging in women a priority. I mean, I think we've talked about why this is so important. So how do we make that a priority? And how do we require the use of sex and age disaggregated data in all research so that we can learn about older women in all areas? And I literally mean all areas. There's so much to learn about. And then to promote the need for a national aging strategy that has a focus on women. Jennifer, you started with that. And I think that's a piece that seems like an obvious, given the importance of this issue. And maybe I'll just end with sort of a piece. I'd like everyone to remember that whether we like it or not, we're all aging. So Women's Age Lab really matters to all of us.
Wonderful. That's a fantastic way to end it. Thank you, Dr. Rochon. This is, a quick dive into such an important conversation. It's an enormous topic. We just scratched the surface. I hope people have been putting questions in our chat box. If you haven't and you've been riveted by Dr. Rochon, please start adding your questions. We're going to take a few minutes now and answer them, and then I'm going to come back and close this off. So I'm just going to change my view so I can see the chat. Oh my goodness, I see lots and lots of questions. I am going to see how I figure out how to, oh my, look at all these questions. That's amazing. All right, so I have someone that's going to, oh, look at all the thank yous. Thank you so much. Oh, Dr. Rochon, people are sending all their thank yous. I hope,
that's so lovely.
I hope you can see that. Okay, I'm going to show my age and I'm going to put on my glasses so I can see the chat clearly. All right, so here we go. Intersectionality seems to be a big theme. While it's essential to look at age and gender disaggregated data, how will you include and gather info from a wider swath of women looking here at intersectional data? So we touched on this a little bit, but I can understand why this is a big theme. Let's talk about that a little bit.
So that is really key. I mean, we've talked about, sex age disaggregated data, but there's so many other pieces that we need to get at to sort of look at the diversity of women. And so we're really committed to finding ways to represent that in the work that we're doing. So just from a very practical perspective, some things that we're doing is we've reached out to some of our partners and community groups where they have a number of groups that are working with people from different kinds of backgrounds. And so we're reaching out to those communities, and we've actually got meetings set up over the coming weeks where we'll be talking with the different communities to start learning about what the issues are for women in their community, so we can start thinking about how do we better reflect this in the work that we're doing. So this is something that's incredibly important for us, something that we need to work hard on to make sure that we're able to get it included and well represented in the work that we're doing. So a very important piece.
Oh, that's wonderful. Thank you for that. I see a lot about training and general practitioners. What kind of training? And we've talked a lot about this, Paula. We talked about this very small number of geriatricians, 304 in the entire country. What kind of training do people get around aging that are in the medical profession? Could you just give people a sense of why perhaps there isn't as much knowledge of aging as we think there should be?
Well, as you said, there aren't that many people that are what we call the super specialists in aging, so the geriatricians. And I clearly firmly believe that there's never going to be really enough geriatricians to do all the work that we need to do. So it's something that training has to be much more diversified. So there's now many family doctors who have training in care of the elderly, they call it, who can help with this and who work in this area as well. But it has to go across all sectors. So it has to be something where, the nurses are trained in this area. Whatever area that you're working in, you need to have expertise in aging, because when you think about it, who's coming into the hospital, who's coming into the healthcare facilities, it often is people who are older. And so everyone needs to be exposed to this kind of training. So that is a very important piece that we need to keep working on going forward.
Wonderful. I'm just looking at a couple, there's so many great questions. So, we talked about, what I'd like to talk about is like aging in place. I think that that's a big piece about the Women's Age Lab and our focus on things outside the hospital. I think a lot of people would expect us to focus on the hospital because we are a hospital. And why you've chosen these 4 pillars when there were so many others to choose from. So what is it about these 4 pillars that you feel will be the accelerant for the work that you're doing? Because everybody knows we just started this in October. Why these 4 pillars? I just think it's really important. A lot of people want to know, how to keep themselves up to date, but these 4 pillars you feel are key.
Well, I think aging in place is something that's very important. As I think we said, 93% of the population are living in their homes in the community, and mostly people want to stay there. I mean, in some cases, long-term care is a very good option, but often people want to stay in their homes. So we need to think about how do we support that and what are the sort of the ways that could make that happen. So I did mention some of the work that we're doing around the loneliness social connections to think about how do we take advantage of where people in cities are already living in proximity to other people, right, and how you could help support them. So rather than, for example, maybe having home care as an example, go in to visit one person and another person from home care visiting another person, how do you support them with, maybe one provider that might be helping a variety of different people, or bring resources in that might make it easier for people to live in their homes. Sometimes for people in their homes, it's simple things like, right now, the snow shoveling, that's something that we've all experienced just recently, can be very challenging, or just being able to access different things that they might need. And so we need to think more about what we can do to address the needs that people have to help them stay in their homes if that's where they want to be. And since that's where most people are, I think we need to find ways to do that better.
Okay, well, I'm going to end there because we're at 2 minutes before. I'm just going to do a bit of a summary. First of all, I'm going to start off by thanking you again, Dr. Rochon, for this incredibly enlightening presentations. Just being in the chat, people want a lot more information. They want to know where to find resources. They want to hear about the articles that you've written, and we're going to get people ways to get that information. So stay tuned. So just as we close off here, I've learned so much here today. Every time I sit down with you, I do. And I think we all have a better recognition about why women's health, older women's health is so important. And what we know is women's health overall is underfunded and under-researched. And that's particularly true for older women. And yet here we all are today. And so there's so much hope. There's so much opportunity in the work that you're conducting. And I believe as women, we need to remember to invest in ourselves. We need to choose ourselves. We need to put ourselves first. And the lack of focus on research into women's health, we don't actually have to put up with it. We can do something about it. We do not have to accept it. And we can be agents of changes in our own lives. So Dr. Rochon has mentioned there are many ways that you can join us in pushing for positive change in the health of older women and building on the crucial work that we're already doing. We're going to take these steps together, and that's the only way we can do it. We have to take ourselves off mute and work on this collectively. This is an excellent opportunity for you, all of you here today, to think about what can I do personally. Paula talked about really getting involved if you love advocacy and talking to your political representatives about including older women in a national aging strategy. For those who love advocacy, that's a wonderful way to go. Request that older women are made a top priority. Ask for that disaggregated data in all research and having a voice in the national aging strategy. And if we work together, we cannot be ignored. We have the numbers and we have the power to change things. You know, Women's is here to help accelerate this important work. And I invite everyone in the audience to keep in touch with us and continue to follow Dr. Rochon's work. Obviously, if you want to make a donation and support the Women's Age Lab, you can do so by reaching out to our team. And we are going to be sending out a short survey to solicit your feedback on today's subject and what you want to hear more about in future events. I hope you'll take a few minutes to share your thoughts because your voice matters and makes a difference. Until then, until we see you again, stay well, and thank you for joining us today for In Conversation With.
Thank you.